Alright, so hormonal replacement therapy, this is typically due to either menopause or if someone's had an ovarectomy where they have the ovaries removed, and we need to replace the estrogen progesterone. Symptoms of estrogen deficiency would be stuff like decreased ovulation or decreased menstruation. A lot of times, especially in menopause, you'll have initial fatigue, hot flashes, nervousness, anxiety, irritability, and or depression. Menopause is technically defined as when you don't have any menstruation for over 12 months or more. With estrogen replacement, it eases that transition from premenopausal to postmenopausal. The treatment needs to be very personalized because everybody reacts different to estrogen, and instead of like looking at blood plasma levels or estrogen plasma levels, doctors go off of treating the symptoms. So it's like, are you fatigued? Are you having hot flashes? And really with these, you want to use the lowest possible dose because estrogens can increase thromboembolic events. It can also increase your risk of breast cancer or endometrial cancers. Besides just estrogen replacement, you can take SERMs, selective estrogen receptor modulators. Ospemifene is one that's used to treat vaginal dryness. It is an estrogen agonist and antagonist. And so in the vagina, it acts as an agonist to stimulate the glands within the vagina to keep it moist. But it is antagonistic everywhere else. Tamoxifen is another one that's an agonist-antagonist, and it treats hormone-sensitive breast cancer by being antagonistic in the breast, and it causes those cancers to shrink. Raloxifene treats osteoporosis. Osteoporosis, it's going to be agonist for the osteoblasts to keep them producing bone. Fertility drugs. This happens if someone is having anovulation. Anovulation just means no egg release. And you can only take fertility drugs if you're not primary ovarian failure. So if you're in primary ovarian failure, it doesn't matter what drugs you take because you're not responding to follicle stimulating hormone or luteinizing hormone. And other options will have to be looked at. Because there's no hormone therapy for that. With treatment with fertility drugs, you can do it in two ways. You can do it in utero or in vivo. In utero, you're just going to use the drugs to stimulate ovulation, and then the couple has coitus within a short window to hopefully catch that ovulated egg and get it fertilized. Or you can go through assisted reproductive technologies, ARTs. This happens where the egg gets ovulated via drugs and then collected and fertilized in vitro. So they're going to expose the egg to sperm or nuclear DNA outside of the body. And then it gets planted back into the egg donor or into a surrogate for that embryo to grow. One of our fertility drugs is Clomid, or Seraphin, and it's a synthetic non-steroidal estrogen antagonist, and so it's going to bind to the estrogen receptor, so estrogen can't. This is going to inhibit that negative feedback, so if you remember, it was hypothalamus, pituitary, and then you had feedback from the ovary to shut down, both at the hypothalamus and the pituitary. But this is going to block that. And so you're going to have gonadotropin releasing hormone causing the release of FSH and LH constantly until you get what you want. This can cause multiple ovulations, which means you can get twinning or more than twins. Urofallopatropin Minotropins and fallopitrobin act as follicle stimulating, so they are FSH agonists. You'll get this via injection, and then you'll also get followed up with an injection of human chorionic gonadotropin to act as progesterone instead of giving injection of direct progesterone. I think sometimes they do still give injections of progesterone, but HCG works too. And so that way, when the uteral wall will be able to support the implantation. On our male hormones, we have testosterone. DHEA is another androgen that is important in male development, but in adults it's testosterone. Both of those are androgens. Androgen is just a male hormone. Typically, you have androgen replacement if there is hypogonadism, so if the testicles are too small, delayed puberty, or impotence due to a result of androgen deficiency. Most commonly, impotence is due to erectile dysfunction, which is not based off of androgens. It's more of a blood supply thing that we'll talk about. Testosterone's anabolic in nature, and so it can be abused. It allows for the building of muscle, of secondary sexual characteristics like deeper voice, broad shoulders, hairy face, right? It also has erythropoietic potential and is used in refractory anemia. So again, we have our HPG axis with follicle stimulating and luteinizing hormone working on spermatogenesis. So luteinizing hormone works on growing the sperm cells, while follicle stimulating hormone helps to sustain the sperm cells. Inhibin is released as a negative feedback mechanism. So luteinizing works on testosterone, follicle stimulating works on the sperm cells. Testosterone also works as inhibitory and goes off to do the secondary sexual characteristics too. Androgenic drugs, oxyandrolone, oxymethylone, are types of testosterone that you can get. Straint is a bucco-muco-adhesive for testosterone. And what it is you get a little pouch and you put it in next to your gums and you hold it there for a little, and it would adhere to the cheek tissue and deliver a steady supply of testosterone, which is really good, especially for younger individuals who need that testosterone. You can also get intramuscular testosterone, but that's about the two ways. So you can either get it through the mouth, intramuscular, transdermal, but you can't take a pill, really. You can't, because it quickly gets metabolized in the liver and in the intestines, and so it won't make it systemically and carry out those androgenic effects that you want. Testopel is an implant that you can get. It can last up to 6 months. Androderm is a daily patch. You move it from spot to spot every day, and don't repeat the same spot within a week. It's just going to decrease the action of that drug. And if it's been 2 months and you still don't have scrotal descent, you have to stop and reevaluate and come up with maybe a different delivery method to get the testosterone you need. Here are a bunch of the different types of testosterone you can get. So with your androgenic drugs, with your testosterone, this is a class 3 drug. So it is in the same group as like morphine, right? It is a heavily controlled substance. You had the Anabolic Steroid Act in the 1990s, and then again in 2004. This includes prohormones. So you take a prohormone and then it turns into the active after you take it. a lot of people, I say a lot of people like to abuse androgenic drugs because they are anabolic. You get anabolic steroids. Helps you to build muscle faster, larger. They do this with like cycling, where you are on the drug for a while, and then you're off the drug for a while, on the drug, off the drug. You do it with stacking, where you take multiple drugs that are different to get an enhanced effect. Side effects, you get stuff like jaundice. You get increased LDL, so you get increased low-density lipoproteins. In chronic use, it's going to have a negative feedback, right? Testosterone, negative feedback up here, on luteinizing, follicle stimulating, and so you end up getting low sperm counts, gynecomastia, which is exemplified here in Bob from Fight Club, where you grow breast. You can also get priapism, your 4-hour plus erections that are painful and can cause permanent damage. And you can also go through withdrawal symptoms with chronic abuse of androgens. All right, erectile dysfunction, it's just impotence. It's an inability to perform sexual functions. It is an inability to get an erection. So it's underneath the umbrella of impotence. Most often impotence is associated with ED. There are about 200 drugs, give or take, that can negatively affect erections, including a lot of your anti-anxiety drugs, your antidepressants, your antihistamines, some of your cardiovascular drugs. They either do this because they're decreasing the blood flow to the penis, or they are decreasing the nerve excitability, or maybe some psychomotor activity that is inhibiting the ability to get an erection. Natural ED is associated with low blood flow, so if it's not caused by drugs, you can have ED if you have low blood flow, specifically with arteriosclerosis, smoking, and diabetes. Diabetes also can cause neuropathies, and so you get decreased nerve excitability. For the erection to happen, you have to have nitric oxide. It is released from the parasympathetic nerve endings that stimulates cyclic GMP, which relaxes the smooth muscles around the blood vessels, causing an erection. Phosphodiesterase type 5, PDE5, stops the erection by metabolizing your cyclic GMP. And so what we see is a lot of the erectile dysfunction drugs are going to work on this enzyme. So they're PDE5 inhibitors. This is going to be stuff like Viagra and Cialis. We also see erectile dysfunction in the female clitoris, and these drugs are being evaluated for that too. Just side note. But side effects: headache, flushing, nasal congestion, diarrhea, rash. Sometimes you can have a loss of hearing, tinnitus, or your vision can be, your color vision can be tinged, because there's another enzyme, PDE6, that deals with the cones in the eye, and sometimes you get a little cross-reactivity there. Again, priapism, erections lasting longer than 4 hours with pain. Gotta go see a doctor because it can cause permanent damage on that tissue. And of course, Viagra, Cialis, they're contraindicated with nitric oxides or nitrates, or because they can cause severe hypertension and cardiovascular failure. All right. Diabetic ED is going to be our bridge to talk about pancreatic hormones and anti-diabetic drugs in the next section.